Good afternoon. My name is Keith Lamb, and welcome to today's Inspire Ask an Expert Anything panel discussion. Today's topic is really interesting to many of us, and some of us are heavily involved in these kinds of patients, and some of us are not. But we all certainly have an interest in the the way that we should be taking care of these patients, because there's really two patients for every donation. So we'll go ahead and get started by introductions. Tom?
Yeah, my name is Thomas Prano. I'm a respiratory therapist in Ontario, Canada.
Donna?
Hi, my name is Donna Tanner. I'm a respiratory therapist in Cleveland, Ohio.
Andy?
Good afternoon. My name is Andy Klein. I'm a respiratory therapist from Chicago, Illinois.
Welcome, team. So we won't delay. We'll just go ahead and get started. So on your screen there, we sort of came up with these talking points that we thought were important to this topic. And so what we'll do here is we'll take each one of these talking points and we'll go through some information. If you've ever been involved in one of our panel discussions, you'll know that we don't get really formal in terms of how you might see a lecture provided with a lot of data and a lot of papers and things like that. Mainly, we rely on our panel to provide their expertise, their understanding of the data, and even anecdote, because we're relying on experts, right? So. But we'll go through at first and say, talk about how do we optimize the donor patient. So a minute ago, when I said there's really two patients, we're going to talk about lung donation today. But we'll talk about how do you optimize the donor patient to prepare them for donation. We'll talk a little bit about ex vivo lung perfusion and regional ECMO during organ retrieval. And then finally, how do we optimize the patient of the management of the recipient once they've received the donor lungs? So first, I thought we should start out with talking a little bit about the donors, right? If any of you are involved in taking care of potential donor patients, then you'll know that the way they become potential donor patients is by death, and really two variations of that, but both variations are dead by definition of the law. So one patient type is the patient type that has irreversible brain damage and cessation of neuro function, and that person is pronounced dead. And so they're pronounced dead, but they still have circulatory function. And so that's sort of that's an advantage when you're talking about organ donation, because even though they're dead, they still have native circulatory function, and potentially they can preserve organ function because of that. The other type of donor would be the patient that has the team has and the family has, if there's family, have decided that the condition that the patient is in is terminal, that there's no chance of recovery, and that person and family can consent to donation after circulatory death. And so what happens typically, the standard approach is that the procurement organization, the transplant surgeons, et cetera, sort of are all on the same page and schedule a specific time when they're ready to take the patient to the operating room. Generally, this is done in the operating room so that they can prep the patient and get them prepared for organ retrieval. Prep the patient, and then sometimes even the family can come into the operating room. They sort of set up a little gallery on the side, allow the patient's family to come in, and then when everything's prepared and ready to go, the patient will be extubated, and they have a certain amount of time to proceed to circulatory death, during which time the transplant team or the procurement team will go ahead and start to retrieve the predetermined organs that will go on to be transplanted in other patients. Now, the disadvantage to this, obviously, is the opposite of what the advantage of being brain dead would be. And that is that during the period of time where the patient is proceeding to cardiac or circulatory death, perfusion to the organs is suboptimal. So because of that, there are certain things that folks have sort of developed, certain approaches people have developed to sort of maximize the amount of perfusion to lungs or organs that are going to go on to be donated. So that's sort of the brief version of what the difference between brain death and donation after circulatory death are. We'll talk a little bit about ventilator management, protective lung ventilation, and then open to discussion in terms of whatever else that there might be to talk about.
Did you want me to change slides there, Keith? Sorry.
Yeah.
Or did you want to just? Okay.
I think you can go ahead and change slides. This first slide really, this paper was sort of a consensus document that was put together by the Society of Critical Care Medicine, the American College of Chest Physicians, and the Association of Organ Procurement Organizations got together and developed this consensus statement. Now, this is a few years old, but when you go to do the literature review on this topic, there's really nothing that sort of supersedes the information that's in this document as far as I'm concerned. So that's why we're using this. So they had a couple of questions that they wanted to try to answer. Now, this document is a very large document, and we can put a link to it in the chat box at some point in time here. And this document is, what's that?
I did. Sorry, I just did.
Okay, cool. So this document talks a lot about other solid organ procurement also, but we're going to specifically talk about lungs. Okay. So some of the questions, or some of the things that as a respiratory therapist we would be interested in, and I don't know anybody who's really been involved in. So in my role, I take care of patients that are potential donors. And then once they are going for procurement, they go on to a different service. They go on to the cardiothoracic service on the other side of the hospital. But for me, what I'm interested in is how to take care, primarily how to take care of the patient that's the potential donor. And I don't know if you can see this slide. Can we make this slide any like for viewers? Is this slide like full screen, or because I could barely read it myself?
I can read it. Okay. I can make it full screen like that.
Yeah,
they can also make the video that they're watching full screen, and it should make it larger even if we're in the side.
Okay.
But we can do that for now.
Better for me. I can read that a little bit better. Thank you. So what makes this? So this consensus group came together and decided they reviewed the literature like all of these groups do, and they put together a list of things they consider to be ideal lung donor criteria, and they came up with this list, which starts out with an age of less than 55 years old, smoking history of less than 20. Pack years, a clear chest X-ray, PF ratio or PO2 greater than 300 on 100%, which would be a PF ratio of greater than 300 with a PEEP of 5. No significant chest trauma, no evidence of aspiration or sepsis secondary to aspiration, pneumonitis, prior cardiothoracic surgery, no organisms on donor gram stain, no purulent secretions or gastric contents on bronchoscopy, and no history of significant chronic lung disease. They went on to say that many centers are sort of liberalizing this criteria, and we'll talk a little bit more about how that might happen soon. But I think that just like any other sort of, any other sort of thing that people want to make happen, if the resources are getting lower, or they're few, the resources are few, meaning donated lungs in this case, then then we tend to liberalize the inclusion criteria. So I think that's what's going on here. You can go ahead. So they had questions. Basically, I think there are three major questions that they attempted to answer here. And the first question was, what is the acceptable lower limit of oxygenation to permit lung donation, and what interventions can improve? So PF ratio more than 300 is something that's sort of widely accepted. And I think that our procurement agency has that in their guidelines. Donors who fail to meet this oxygenation threshold may have other things happen, like they may change their fluid administration. They may diurese more, and this would be basically for oxygenation requirements. And maybe even things that are found on chest X-rays. And as some transplant centers, as part of an investigative protocol, lungs that fail may be subjected to ex vivo perfusion. We'll have Donna talk about that a little bit in a minute, with the expectation that many of these organs will ultimately prove to be acceptable for transplantation at some point in time. The second question they ask, are there specific mechanical ventilator settings that should be used to support potential lung donors? I have a lot of thoughts on this topic, and I think that the other panelists will too. But essentially, they suggest that mechanical ventilation approaches be similar, if not the same, as they would be for anybody else. Okay. Should bronchoscopy be performed on all potential lung donors? It seems like it's a resounding yes from these three organizations, that bronchoscopy should be performed on all potential lung donors to look for and evaluate for occult bulk aspiration and infection, and to perform therapeutic airway clearance. And finally, I think this was the last question that they looked at. Is there a specific fluid management strategy that is optimal for lung donation? Fluid management protocol is aiming for neutral or net negative fluid balance to avoid volume overload and maintenance of volume blood pressure with vasopressors, rather than aggressive fluid resuscitation are recommended. So this again is almost synonymous with the way that we take care of sick intubated ARDS patients. So there are really two. So we talked about two different kinds of patients that would potentially be a lung donor, and one is the brain dead patient, and one is the donation after circulatory death patient. And so whenever there is either the potential for or there is indeed a low perfusion state, then oftentimes if the center that is taking care of these patients offers it, they will place the lungs on ex vivo lung perfusion, and or now the latest thing, the most recent thing that I've become aware of is regional ECMO, which can either be done for organs in the chest or even organs in the abdomen. Does anybody have anything they'd like to add to that? Donna?
I don't think at this point. I just know as far as EVLP, we always talk about what the ideal donor looks like and what those ideal lungs look like. And those are less than 1% of what's really out there. So EVLP really gives us a chance to optimize those lungs to give them to the donor or to the recipient, more like. So it's been huge. It really has. And I think as it grows across the US and more centers really have their own in-house EVLP programs, we've really looked at expanding, that donor pool just tremendously.
Should we briefly describe EVLP for anyone watching that may not be aware of it or they don't provide it in their center?
Yeah, that's probably a good idea. So from my standpoint, EVLP, ex vivo lung perfusion, it's a perfusion machine, and it helps optimize, improve that VQ relationship, that ventilation perfusion relationship, take those less optimal lungs and make them optimal. Take those donor lungs that may be wet, boggy, maybe does not have those ideal numbers that we're looking for, the PF ratios. And we can ventilate these lungs, we can perfuse these lungs, we can increase that PF ratio, we can drain some of that fluid off of them, we can oxygenate and ventilate and get them to the ideal stance so we can transplant them safely.
Yeah, and I never want...
Go ahead.
So I was just going to say, I never want to make the assumption that everyone immediately understands that the word ex vivo is the first part of that, which means the lungs are actually removed from the donor first and placed into a protective chamber. And then we ventilate them like we would as a student ventilating, if we were ventilating animal lungs in our lab, essentially, like we're perfusing and ventilating these lungs outside of the body in a protective chamber. So it's important that people don't miss that first part of ex vivo. This isn't something we just do while it's still on the patient. It's pretty fascinating to see, and it's pretty remarkable what it's done for lung transplantation.
Yeah, literally lung in a box. That is as primal as you can get it. It is lungs in the box, and it's fascinating to see. They're fascinating to work with, and it's, I think at one point, what was the last statistic? 15 to 30% of patients die waiting on the list. So, and those numbers are, very reduced from what they were 10 years ago when it was well over, 50 to 70%. So just by using things like ex vivo lung perfusion and, doing these enhancements, we've really increased the donor pool. We've not only increased the donor pool, but the recipient pool.
So yeah, how long? So Donna, at your center, do you place any donor lung on ELP, or just the ones that you think are having problems?
So just the less optimal ones, which unfortunately that's more of those are more of our statistics than not. But when if you're going to get an ideal lung, that comes by, there's no need to really do much with it. You can just go ahead and transplant it. But when we have those that aren't that ideal, then you can go ahead and put them on EVLP. So I would say organizationally, we probably place about 10 to 15% of our lungs on this. We give it 3 to 4 hours, which is pretty much the standard. If they haven't improved by that sweet spot, then they are not transplantable.
And what do you use as a marker of improvement? Gas exchange?
We use gas exchange, fluid removal, and there's a whole chemistry and mathematical workup that's literally on the boards of that designated OR for that is well beyond my comprehension of everything that goes through. So right. Once it has, and it's constant, it's always constant measuring. So once they have been deemed, and pretty much by going into the second hour, are we improving or are we not? Because anything after that second hour, if we haven't made much of a progress, then chances are by hour 4, we're not going to get there either.
Right. Did anybody have any questions yet, Tom? Anybody in the chat box?
Nope, no questions. I was gonna ask Michael Bunn if he wanted to join the call. I can flip his switch and it might allow him in here. Because it looks like we have an organ procurement coordinator from Central Florida, and there may be some additional comments that they may want to chime in. So let us know, Michael, if you're still watching. I can send you an invite. Maybe you can tell us what exactly that role is. That would be helpful for those watching as well.
Yeah, so in the meantime, so if we could just kind of recap what we've talked about before up until now. We looked at the consensus conference and a consensus document, and basically the recommendation in terms of ventilator management is to use protective, low stretch, low, the term mechanical power wasn't probably universally used then as it is now, but low stretch, low power, low energy, lower levels of iatrogenic inflammatory response that then goes on to make outcomes worse. So in terms of a ventilator strategy, it doesn't seem like there's any compelling data to say for the potential lung donor. We'll talk about the lung recipient here in a few minutes. But for the lung donor, it doesn't seem like there's compelling data to stipulate using any other kind of approach than the one we already use for patients that are intubated. Anybody have anything to tack on to that at all?
Well, I think we could be a little bit more specific and say essentially we're talking about lung protective ventilation. I think we've entered the age now where we consider protecting the patient's lungs, whether or not they have ARDS. We may get a little more aggressive with lung protective ventilation when someone has severe ARDS. But in terms of the management, we are, aiming to look at optimal ventilator settings. What we call optimal ventilator settings now is essentially translated to lung protective ventilation for the most part. It's also there's also a study I did sort of do a quick lit search earlier and found there was a randomized trial looking at conventional. Now, keeping in mind conventional at the time of the study. This study was done in 2010, but conventional management for lung transplantation recipients was still using higher tidal volumes because really they were trying to expand and optimize these lungs by, I would say, older school methods. But they did a randomized trial. It was unfortunately stopped early due to funding issues. But they did have over 100 patients included. And by using lung protective ventilations, which was, so traditionally it was tidal volumes 10 to 12 and PEEPs of 3 to 5. By using PEEP of 8 to 10 and 6 to 8 mils per kilo, they had a significant increase in the number of patients that had optimal lung condition when they were looking at donation. I can put that link in the chat as well.
So that sort of supports what the consensus of folks said, and that was that the closer we get to using standard lung protective approaches in potential lung donors, the more likely that we'll have lungs that are considered appropriate for donation.
Yep. And welcome, Michael.
Is that you?
Hey everyone, yeah, it's can you hear me? Okay.
Yeah.
Yep. Yeah, we can hear you.
Perfect. Sorry, yeah, I wasn't prepared to be on camera. My air conditioner's been broken for a week and they just reinstalled the new one just now and I can feel the air circulating, so it's gonna be a good day.
Yeah.
But yeah, my background, I am a respiratory therapist in the organ procurement coordinator role, which is fairly new. I got into this role about 3 years ago, which is fantastic for respiratory therapists since it is a whole nother pathway that we can go on the level of nurse practitioners, being able to put your own orders in with full autonomy. And there's no better feeling than getting a pair of lungs that people don't think are going to go for transplant, and then you can turn them around within about 72 hours and get them transplanted into a human. It's one of the most it's the greatest feeling ever. So it's a fantastic job, and thank you all for putting this on today.
Well, thanks.
You're welcome. Thanks for joining.
So that being said, I have taken care of potential donors for a long time. Primarily practicing on the trauma service dabble in the neurosurgery service. And so I see quite a few potential donors. And in my experience, I've been an RT for quite a while, and I've always wondered when and Michael, maybe you can help me with some of this too, but I've always wondered why the disparity between what the donation folks want us to do with the ventilator and what we normally would do with the ventilator. Not only the ventilator, but other things too. And let me give you a couple of examples. It's been some time now that recruitment maneuvers probably have sort of been out of vogue and not as popular because of a couple of trials that have given us data that suggest that doing recruitment maneuvers may be more injurious. The potential risk of doing those on patients might outweigh the potential benefit. So I've always wondered if some of these disparities between what the OPO folks want us to do and what we want to do are that they're really onto something new. Are they onto something that we don't know, or are they behind? In other words, have their protocols just sort of lagged behind what we think that we should be doing in the ICU? So recruitment maneuvers is one. I've seen some protocols that suggest giving hypertonic saline empirically to patients that might be a potential lung donor. I've seen people protocols that stipulate Q4 bronchodilator therapy, and of course, the bronchodilator therapy and the hypertonic saline are things that we would never empirically do to other ICU patients. And so, is there something there that may be of benefit? Chest physiotherapy, bed module, things like that empirically, even though we don't do those to people that are not potential donors. And finally on my list, my quick list that I wrote, man, they seem to like to do a lot of ABGs. And so which our paradigm shift has gotten away from, right? So for the modern ICU, the paradigm shift has been, man, do you really need to do a lot of ABGs? Because what might happen is they're trying to fix an ABG that may not be harmful. Acidemia for the most part isn't harmful, and patients that have single organ failure, so these ABGs may there in turn create the false sense of need to make ventilator changes that then cross some of these protective thresholds when it didn't need to happen to begin with. So anybody have any experience with some of these strange requests from the OPOs that sort of are misaligned from what we think is standard practice?
So those ABGs that we ask for all the time, they're more to check the PF ratio than anything. Most centers do want to see those PF ratios above 300. We like to keep ours above 350. So just kind of, do we have to switch the ventilator modality to get that to happen? Do we need more therapeutic bronchs? They're going to they want to prone more patients and therapeutically bronch every 4 hours, which is what they do up in St. Louis. But that's mainly the main reason why we want to get those blood gases every 4 hours, just to make sure that our PF ratio is high, getting higher, and not dropping. But that's just from what I've experienced.
Yeah, and so to piggyback on that a little bit, I've also seen protocols that say, okay, drop the PEEP to 5 when you do this, what they're calling an oxygen challenge.
Oxygen challenge, yes.
And so in the other world, in the no transplant world or organ procurement world, we think of maybe dropping PEEP as sort of potentially more injurious than leaving the PEEP where it is, particularly in for short periods of time where we may cause atelectasis. We may, I did a talk about this recently where we talked about, well, how do you set PEEP? And we know that, and potential donors are not excluded in this. We know that the median BMI for patients in an American ICU is above 30. It hovers just above 30. And there's some data that suggests that you could, that people who have abnormally high BMI should be on more PEEP. So I just wonder, so to me, if you believe some of that, and I know Tom doesn't believe in the BMI divided by 4 data that had like 6 patients in it, and I don't necessarily hang my hat on it either, but I do think it's probably better than just guessing, right? We never had any literature to support to use 5 a peep. Everybody says, well, we've always used 5 a peep on everybody, but we never had any literature to support that number either. That just was a number that somebody came up with. And I was talking to somebody the other day about this, if a physician, an intensivist, and he said, you know what other number never had any literature to support, but we use it all the time, is that transfusion threshold of 7. Right? That transfusion threshold of 7 was a number that was just pulled out of thin air, but we follow it, like it's substantially supported by the literature. Anyway, I just wonder if dropping the PEEP to 5 to just in order to do an O2 challenge is really current. Like, is that really supported by the literature?
The way that surgeons have explained it to me in the OR is that's the best way that we can predict what the lungs are going to look like outside of the body once they go into the cooler to be transported back. So they do inflate the lungs, clamp the trachea, pull the lungs out, and they put them in the bag. They want to make sure that PF ratio is going to be super high and can sustain that travel. So that's why they want us to drop we usually keep our donors at a PEEP of 12. And we drop them down to a PEEP of 5 for 30 minutes on 100% and get that O2 challenge and then go right back up on our PEEP. But that's just what they want to see. I mean, I don't know if there's any literature behind it, but that's just the gold standard that we've been following since I've been there.
I mean, I can essentially see the rationale why you want to challenge somebody on the lowest possible settings and then the highest FiO2 just to see the gas exchange on it. Because the idea is that you're trying to, put these into a recipient who may have been waiting for these lungs on a respiratory ward somewhere. They may have been waiting at home, right? They weren't in an ICU themselves on a PEEP of 12. They're waiting for a set of lungs. And then the question is, can these lungs even function without mechanical ventilation, particularly PEEP? So I can understand the reason behind it. Just to comment a bit on the recruitment maneuvers, I agree with your points, Keith, that they're out of fashion. I do know, however, that most of the protocols will say things like 30 centimeters of water, and they don't normally, well, again, the protocols here in Ontario anyways, they don't normally advise going higher than 30 centimeters of water of a sustained inflation. Most of the guidelines that are being strongly recommended against now are including pressures greater than 35. Having said that, there's also literature to suggest that 30 centimeters of water does nothing for recruitment because it's not high enough. So you have both sides of the story. You could have people who are strong proponents of recruitment maneuvers that say 30 does nothing, you should do higher. And then you have those saying, yeah, but higher, we have evidence of potential for harm, so you shouldn't go higher than 35. So it's kind of like, why are they still doing it? I think it's just an idea of like, if there is something that can recruit, the idea is that if you're using recruitment maneuvers, the only way to keep the lung open after you do it is to have some sort of PEEP strategy. So the routine use of them is what sort of gets frustrating for RTs that understand the literature, is that routine use of recruitment maneuvers and then putting them back on the same PEEP level they're on really aren't helpful. But generally what happens is after performing this maneuver, we're asked to do blood gases to see if there was any positive response to this. Again, I think it's more of a fixation on numbers. I understand why they want the higher numbers, but of course they're trying to do anything to improve the numbers, which we know doing a recruitment maneuver, if you do a blood gas right after, you may actually see an increase in PaO2. The issue is if you do it 30 minutes later and you haven't done another recruitment maneuver, it's probably going to fall back down to where it was if you did a blood gas before doing the recruitment maneuver. So they're really just trying to get the best numbers possible, but are they painting an improper picture of the donor lungs? That's another question to be answered, but I think that's where a lot of it stems from. Maybe others would agree or disagree with that, but I think that's where it sort of stems from.
Yeah, so that sort of, I agree with you 100%, Tom, obviously, but if we were going to do a recruitment maneuver, and then we're going to drop the decremental PEEP titration ideology would be to find the optimal PEEP, right? And then after a recruitment maneuver, and then we're going to drop the PEEP to 5 to do this Q4-hour oxygen challenge anyway. Is there any net benefit to any of that.
No, again, I think the purpose of that is not to see benefit. I think it's just to see how bad these lungs really are. Because the question is, if you're doing recruitment maneuvers and you're trying to optimize fluid management of the pit, like all the things we're trying to do to optimize the organs, the question is, at one point, could you possibly drop the PEEP and get an acceptable blood gas? And I mean, if you continually see, no, you can't, I think the bigger picture we have to consider is that when we think of things that are bad for a patient, we think of studies that have looked at perhaps maybe a vascular level, like preclinical data, but a lot of us look at outcome data, and of course this patient's outcome is already determined, and they're just trying to see the condition of these lungs and what extremes they can manage and what extremes they can handle prior to lung transplantation. But I agree with you. It seems totally counterintuitive to recruit the lungs for one step, and then the next step you're dropping them down to people 5 on 100% and just hoping for the best. But again, I think it's just to see the extremes of what these lungs are capable of. Is there any difference in those, doing those maneuvers? If the lungs are optimal, then it may not matter what you're doing. You're going to have the same result with blood gas. But for patients' lungs that are clearly have had some injury prior to this process, they probably will show pretty drastic changes in blood gases when doing this.
Yeah, I agree. I just would still maintain that part of our approach to maintaining appropriate lungs for transplant into another patient would be to not cause harm. And I'm not sure that we're not doing that, at least at some level, when we drop somebody to 5 a PEEP that maybe should be on, based on their body habitus even alone, maybe should be on higher PEEP at a baseline.
Yeah, I don't disagree with you at all. I think the hope in general is that the process doesn't go on that long. Ideally, if you have a donor, you want that process to be rather quick. So I think the bigger concern for me is if we were doing this practice for 2 or 3 days, awaiting brain death, for example, on a patient, and we're doing this to the lungs just to try to optimize them and potentially causing more injury. So I agree with you. I think ultimately you want this process to be like, okay, this patient's eligible for lung donation. You hope that this process is going to be rather quick. If it is brain death, can we do an apnea test? Can we get this things, can we get these things ready and sort of get this process onwards? Maybe Michael, you can comment to this. Like, what's the hopeful turnaround from the moment you determine someone can be an optimal donor to the time that you're actually, harvesting the lungs? I think the idea is to get it obviously rather quickly. You don't want to drag this out. You just want to make sure they're optimal.
We want to go before 72 hours of authorization. And the sad thing is the lungs are always the first organ to get ruled out. So no, everything you're saying is spot on, and it's always a guess. There's no hard facts on anything yet, and it's doing the best that we can with what we have. But 72 hours, you want to go as fast as you can.
So how about the Q4 bronchodilators that we don't do on people that are alive?
Yeah, we do those. That's in our protocol.
Good. I've seen it, certainly, and argued the point. I don't know how much risk there is to giving somebody Q4 bronchodilators that don't have reactive airway disease. I'm not sure what the risk is, but I know that the benefit certainly isn't there. So I don't know. I don't know why they're in some of these protocols.
Yeah, I think someone at one point said that they benefit and they've been running with it ever since. I think they were going to try and put mucomist in our new protocol, and we shot that down. Now that they are integrating respiratory therapists into this role, I mean, I think we have 6 respiratory therapists now that are the coordinators, and I think we're going to start making a pretty big difference on how we look at the ventilators. It was all very cut and dry, and every patient is the same, goes on the same exact settings, and we're trying to expand on that and change that.
Right.
I think having input from respiratory therapists is really a good move. Historically, I think it's been mostly just physician and nurse driven, and I think having the input from RTs is a good step forward.
Absolutely. Respiratory therapists are a huge part of the team, and I love to listen to the respiratory therapist that's working on my donor. I mean, RTs are super smart, and I just don't think they've gotten the credit, especially in organ donors as well. So
cool. So And we appreciate the work you're doing, Michael, for sure. Can we go to that next slide? Okay, how can we optimize the management of the recipient once they receive the donor lungs? I'm going to go ahead and go to the next slide. So Madison, who we all know, not too long ago, did a really extensive literature review and did a journal club presentation for our state journal club. And so I asked her, I said, hey, can I see your presentations to save me a little bit of time? And so I looked at her data that she collected, and I wound up just taking her summary slide because her summary slide was really good and has some talking points. So her and she did this journal club presentation with Chris King, who in Northern Virginia is the medical director of advanced pulmonary disease and transplant. So he really had a lot of good input for that journal club presentation. Anyway, so basically a summary of all the literature that she looked at and the data she looked at in terms of how to take care of patients once they've been transplanted with the donor lungs is fairly almost synonymous with all of the things that we talk about daily in terms of protective ventilation. So what she came up with here was the norm would be to start with volume control ventilation at 6 cc's per kilogram, like we all do. Now with an interesting phenomenon, maybe not that interesting, but something that's important to think about is that with the donor lungs, while they're still in the donor, there's really no risk of patient self-inflicted lung injury, right? Because they're all apneic. They don't have they don't have a respiratory drive. However, that's not true for the patient that receives the donor lung. And so as they're all intubated post lung transplant, there is the potential there for self-inflicted lung injury. And so that becomes really important when you start to talk about their ventilator management. So starting out with volume control, obviously wanting to minimize dysynchrony to some extent. I know Tom has different varying views of whether or not dysynchrony is always harmful or it's not. But let's assume that in a patient that has just undergone lung transplant, for them to generate really large tidal swings and pressure swings probably is injurious. And so keeping the driving pressure less than 15, just like we normally would. And another interesting phenomenon is I think that they really try, and Michael, you can correct me if I'm wrong, but from the literature I've reviewed, anyway, they try to keep the size of the lungs similar, right? Similar in the donor and the recipient, but that doesn't always happen. So using predicted body weight to evaluate for volumes, the predicted body weight of the donor, which may not always be, that information might not always be available to the end user, the person at the bedside and the transplant ICU. Right? What's that? May not be available, right? So anyway, I think that finding that information may be difficult. Keeping the driving pressure less than 15, transpulmonary pressure less than 20 if you have a way of measuring that, esophageal manometry, plateau pressure less than 30, and then the PEEP individualized to the patient like we normally would attempt to do in an ICU patient that's intubated on the ventilator. So like I said, P-Silly may be an issue. And so you have that to sort of contend with too, making sure that the patient isn't causing themselves harm with his spontaneous pressure and energy swings. And then managing them like you would other ICU patients, where if that's an issue, then maybe neuromuscular blockade might be, and higher sedation levels might be appropriate. Another thing that's really important is primary primary graft dysfunction, or PGD, and so that's something that's specific to the recipient of the donor lung too. And in my review of the literature before today, the PGD is really a primary reason for failure of lung transplant. And so that's an important thing to be concerned with. So my question would be to the group, if P-cilia is potentially a problem, lungs that are smaller than the patient normally would have, the native lungs are smaller than the lungs they receive are smaller than their native lungs, and this post-graft issue is a problem. How does any of this play into individualizing the ventilator support for a lung recipient, if it does at all?
Yeah, I think it all plays in 100%. Looking at the slide, I have to laugh when Madison did this of, donor predicted body weight. Those of us that have been doing this a long time and have worked with the surgeons in the CVICUs, the lungs, when the patients came up, were either a good fit, they were smaller, we jammed them in there. That's pretty much all we knew. And that's how you had to ventilate, given those parameters. But you knew if the lungs were small, that how you had to ventilate. If you knew that the lungs were almost a little too big for the patient, how you had to ventilate. And if they were a perfect fit, we knew how we had to ventilate. But I will say, as far as the PGD, that's the biggest reason for readmission for any of these patients. It is the biggest reason for failure. And it's something that we probably don't trend as much as we should, especially on the RT side of things. We don't catch that end of things of increased oxygenation needs after extubation. And this is after the patient has looked like they're going to be successful. And now all of a sudden we're not oxygenating very well. We see changes on the chest x-rays. So every single point of this is 100% individualized for that patient. And we're not going to be able to see that even the first, 2 or 5 hours after surgery. It takes really some fine manipulation at the bedside with an entire team to figure out that special recipe for that patient.
So do things like, what makes the primary graft dysfunction worse? So from what I understand, the PGD is really the most common reason for early mortality in a lung transplant patient. Mm-hmm. What, if anything, about the ventilator management either exacerbates that or mitigates that? Is it based on all of the things that make the secondary inflammatory cascade worse in any other pulmonary patient that's intubated, or is it different? Because we're talking about the graft, right? Specifically, should we have a lower driving pressure threshold, lower plateau pressure threshold? Should we use lower PEEP or higher PEEP?
I just sent a message to a colleague of mine that works at Toronto General Hospital, where I used to work, and they're probably I would argue probably the largest lung transplant center in Canada. I'm not saying North America, but in Canada, they're pretty active. This is where Dr. Eddie Fan works, and Neil Ferguson. And I mean, they're not the lung transplant surgeons, but just physicians that all of us on the panel are usually aware of. So I just sent a quick message and I said, do you guys have any post-transplant limitations? And the comment was unofficially, meaning they just all do this, but it's not like it's written in stone. They just everybody's aware of this. They teach all the new grads, etc. They like to keep peak pressures less than 30 and plateaus about 25. So generally slightly lower than what we would traditionally accept. Plateaus of 28 or 30 in many patients. They like the plateaus being less than 25, so they do like a more safer upper limit. They definitely avoid recruitment maneuvers at all costs, specifically a fresh transplant. This is due to the anastomoses. They don't insert esophageal balloons because of the anastomoses. They don't want to potentially cause any issues with the suture site when they're inserting esophageal balloons if it's going in the wrong direction, or even if not, because I mean it's very, very possible to go right where the suture is. So they definitely have some unofficial lower tolerance of limits. So again, but they, as she said, unofficially. But this is just their common. We all have those unofficial things that we all do that might not be written in protocol, and this is one of them that they just like slightly lower safety limits, so that they're not having that potential for injury. Specifically, their biggest concern, of course, is the anastomosis site. And I used to work there when I was a fresh grad, and I know that was always a concern. This was the only time we would use a jet ventilator on an adult patient, for example, was like a post-transplant patient that's just going into rejection. And it was just because we wouldn't put them on something like an oscillator or high levels of PEEP because we were just worried about the suture sites. Fresh transplant.
Yeah, it sounds like an approach I would come up with if somebody asked me to make one up. I would say, hey, whatever we think is safe in most people, let's drop that down. Just
drop it a little bit, yeah,
for
sure.
A fresh lung transplant patient.
Yeah. And there was one question sort of related to recruitments. Pablo was asking, like, is there a certain pressure that one should be cautious post-transplant? And to be perfectly honest, any pressure post-transplant poses a potential for, I mean, this is why ideally we would love these patients to come off of positive pressure mechanical ventilation as quick as possible. But ideally, specifically very post fresh transplant, we should be avoiding elevated pressures at all costs, really.
And I'll add to that too, Tom, because you specifically asked about the PV tool, which is on the Hamilton ventilators. We use those at our hospital. I think, to your point, the PV tool, which anybody who's used the Hamilton ventilator, it's a slow pressure volume maneuver that walks the pressure up past the upper inflection point, and would then, I would say, be counterintuitive to everything we're talking about, because it runs these pressures up into the 30s and 40s and holds them there, and then slowly walks them back down and takes measurements along the way. And it can give you some interesting information, but I think in a patient like this would be somebody I would probably try to avoid using that maneuver in, especially freshly post-op. I don't know what anyone else thinks about that.
And I think it's important to have these conversations also, like definitely reach out to other centers, maybe centers with more volume of transplantation, maybe longer experience, maybe they have similar volume, but they've been doing it longer. And you may learn a lot from different practices. But definitely, always question local policy if it seems like you're doing something that we would even have potential worries in adult patients that aren't post-transplant. Like, I would be concerned using recruitment maneuvers or a PV tool in a normal ARDS patient. I'm not saying that I wouldn't ever, but I'm saying I would be very cautious. So then you have a post-transplant patient, that caution level should increase, which means your upper limits and allowance of these things should really be sort of drawn in a little bit.
Could you bring up Madison's question about P-cilia?
Here we go.
Anybody have any feelings on this? Anecdotally, I feel that many of these lung transplant recipients, and Madison actually takes care of these recipients. I take care of the donors, and she's on the other side of the hospital taking care of these recipients, have a significant level of anxiety pre-transplant that worsens post-transplant. To push to wake these patients up early may create a greater risk for P-cilia. I agree. I think I agree with what she's saying, but I wonder if this is even more reason to get them extubated off the positive pressure to begin with. Anybody
and the question is, what sort of criteria do we accept when, for SBTs on patients that are post-transplant? Like, can we use the same numbers we use on patients who are, have their own intrinsic lungs? Like, it's a very challenging subject, I think. And I think, and to be honest, I have another anecdotal thing with this too. I remember when I worked at the transplant hospital, when I worked at TGH, I used to always think to myself, man, I would never want a lung transplant. Like, that's what would always go through my mind. And then someone reminded me one day, I'm like, do you realize how many patients get transplants and they're out of the ICU in like 3 days and you never know them? And the only ones that you remember are the ones that literally are these anecdotal patients that we see with high drives, making their lungs worse, or getting ARDS post-transplant. Like, we remember these patients and their course is extremely complicated and long. And of course, that's what we that's what we link to a post-transplant patient, right? So we have to acknowledge that these are obviously potentials, potential things to be concerned about. But we also have to realize that I think many patients, we hope that the faster we get them off the ventilator, the better. And we're only going to remember the ones that are super complicated. And so it's hard to say whether or not PCILI is an overwhelming problem with transplantation, or if it's just something that we definitely will see. And that's what we're going to remember, hands down. But clearly it's an issue when you have a super strong, because these are patients who were in respiratory failure for probably a good part of their life prior to getting transplanted, right? They had lung injury requiring new lungs. So they probably have a high degree of anxiety. They probably had, if you were to ventilate these patients with their original lungs, they probably would have a ton of evidence of possible PCILI, like high P0.1s, et cetera, because they have horrible lungs and probably horrible anxiety related to their lung condition. So the question is, post-op, do we then heavily sedate and or paralyze these patients, which we know has negative outcomes, or do we just tolerate a certain level of high drive and hope that, and again, getting them off the ventilator, but how do we utilize our current criteria for extubating patients? Like, how do we translate that over to a patient who is such a unique, has a unique condition? I think that's a challenge in its own. Sorry, I just sort of rambled there.
That's okay.
I tend to do that.
I agree with your rambling. So Denise Hunter from Tempel brought up EIT.
Yeah. Yeah, I was going to say, I mean, as fascinating as this might be, like, I don't disagree that optimizing a lung with EIT prior to harvesting the lungs and then looking at the lungs after is fine. But I mean, this would need to be a study that compares it to something else. I mean, it's just looking at it doesn't mean that it's any different than something. So there would need to be a control. So, I mean, I would love to see that study, but if it's not published and there's not a control, then it doesn't really help us to determine that this is the optimal way to procure lungs. That's just my comment. And I love EIT. Don't get me, like, I think everybody on this panel knows I'm a fan of EIT. Just like when someone says something like this, I just want to make sure that, we understand that just looking at, if this was a study, was it a few transplantations? Is this a case study? Is this just looking at their lungs pre and post and they look great? Again, because I can tell you from working in a lung transplant facility that, as I mentioned earlier, some patients are on vents for 3 days and off the vent. They never have a lung problem post-transplant, and they probably didn't have their lungs optimized with EIT prior. So there's still this possibility that they just had really good lungs, rather than it was the Pulmovista or the EIT Tempel or, any EIT device that made their lungs perfect. So there would need to be a significant level of control in a study like that to prove that point.
Yeah, lots we don't understand about EIT and its potential for sure.
I think it's a great use for it, but if we're going to say things like it's, if we were to start to have, like, before this would come into any recommendations, for example, there would need to be significant studies with controls to ensure that this was actually a major difference. As much as I love technology, I'm also a big skeptic when there's not evidence, a decent amount of evidence.
Agreed. I think everybody here has the same opinion. Donna, do you have any idea what your benchmark is? Like, how quick do you typically get transplant patients extubated?
So I can't lump them all into one. If we do the nice little CFers, those are great transplant plants. I love them. And sometimes we even just extubate them in the OR. Pulmonary hypertension ones, we extubate in the OR. The COPD ones that are single lung transplants, those are the bane of my existence because, we're coming out with double lumen tubes. We have the issues. We also do, heart lung transplants. So we have benchmarks for each of the different individual ones, but it's unfair to lump them all into one. And then we're also at a facility that most of our lung transplants have been rejected to 2 or 3 other facilities before they get accepted to us. So we already know that we're getting into a world of hurt before we even get them, out of the OR. But ideally, if we have that perfect picture patient that comes in, didn't need EVLP, and they came up to the ICU, if we could get them extubated within the first, 4 or 5 hours, and then probably up to step down, maybe post-op day 3. But then there's a whole nother, discussion after that, because it's a huge thing on getting that diaphragm up and moving, and then getting them up and moving. We're huge components of physical therapy. So it's never one easy answer with that.
Good stuff. Well, the boss is telling me to wrap up. It's 1500. It's been an hour.
First things first. Brady, how are you?
Yeah, Brady.
Oh, wait, your voice, your microphone's not there. That's not why you've been so quiet, is it? I see you're not muted, but I don't think it's connected to your headset. No, can't hear you.
Can you hear me now?
Oh, yeah, I can hear you now.
Oh, there he is.
You guys didn't respond to me, so I realized I was just going to sit here and be quiet.
That's why we didn't respond to you.
The only thing that I was going to say is it looks like there's a tremendous amount of research that RTs could be doing here. Collecting data, observational stuff like Michael's team. Looks like you guys have a lot of opportunity to add to the literature to improve things as they are. I don't keep up with this literature much, so I don't know where it mainly comes from. I don't know who's doing a lot of it, but sure seems like a lot of questions and things that could be addressed by RTs. So hopefully we could get some people interested in this area.
Yeah, I agree.
That's all I had.
All right. Well, thank you. I want to say thank you to everybody. If you will, anybody that's on that's watching this would go to our website. There'll be a recording of this available for you to use to do whatever you want to with it. Also, you can reach out to us and give us recommendations for future expert panel discussions. It sounds like maybe we could have another one on this topic at some point in time once we've done some of this research. So, Michael, I appreciate you. Appreciate all the other panelists, and I appreciate everybody that logged on to watch this today.
And thanks to Madison, she's sort of she's like behind the curtains right now, just sort of adding some comments and stuff like that, and trying to keep Keith on time. Thank you, Madison.
Yes, thank you, Madison. All right, folks. Well, thank you so much, and we'll talk to you soon.
All right, take care.